Hello, everybody. I am Darren Rolls, the Director of the HIV Supports Division in the Aging and Disability Services Administration at the Minnesota Department of Human Services. I use he, him pronouns. For folks who are not seeing the video, I'm a middle-aged white man with clipped hair, that means bald, and a light beard presenting from my office with a blue-green background. On behalf of the Department of Human Services and the Minnesota Board on Aging, I would like to welcome everyone to the second webinar of our 2025 Odyssey webinar series. We are so excited to have you join us this afternoon. During today's webinar, we'll learn more about the intersection of HIV and aging, including common health concerns and quality of life considerations. We will identify actionable steps to support communities aging with HIV. And we will hear a firsthand account of a lived experience from a person aging with HIV. I've personally been doing HIV work for over 30 years. For folks who experienced or learned about the early days of the AIDS epidemic and crisis, we remember that treatment was non-existent and an HIV diagnosis was essentially a death sentence. Of course, there have been so many advances in HIV care, and we now have the tools so people with HIV can live long, healthy lives. And that means they're aging. It's amazing. Currently, over 50% of people living with HIV in the US are older than age 50. You'll learn more about some of these demographics today. Folks aging with HIV face some unique challenges. They also face common challenges with aging, which many in this audience work with every day. As more people age with HIV, they are needing supports outside of HIV service systems and more frequently connecting with mainstream aging and disability services. Here at the Department of Human Services, we are taking intentional steps to deepen work across HIV supports, aging, and disability partners to be sure providers in each sector have the tools they need to support folks with HIV as they age so they can live their best life. Today's session is just one piece of that work. Thank you for joining us. I'm excited for the timing of our session today as it is National HIV, AIDS, and Aging Awareness Day. As planning for this webinar kicked off, we knew it was the perfect day to bring together partners and people from across Minnesota to learn about this topic. And I'm extra excited today as we have two dynamic presenters here with us. And before I introduce those presenters, I have some quick housekeeping reminders. Our audience today is automatically muted. Cameras have also been disabled for everyone not presenting. The Q&A or question and answer feature is being used, so please feel free to enter your questions for today's presenters. The Q&A will be monitored and questions not answered during the presentation will be saved for the specific question and answer portion of today's webinar. If you need technical support, you can submit your request here. Start your message with TECH, T-E-C-H, and one of our staff members will respond to you with support. Accessibility information, including how to access captioning and ASL interpretation services, was sent to registered audience members on Tuesday, September 16th. If you need some assistance accessing these services, please contact us using the chat feature. Next, if you would like to change your screen view, you can use the layout button near the upper right corner of WebEx. Also important information, we will be sending certificates of attendance to everyone who participated in today's webinar within a week. CEUs have been approved by the Minnesota Board of Social Work. You may also self-submit this event to other professional boards or training transcripts. There is a post-event survey that we will ask you to complete. This will also be sent within a week. We use this information to improve your experience, so please take some time to fill it out. And we are recording today's webinar. Once the recording is made accessible, it will be posted for viewing. Please note that certificates of attendance will not be available for watching the webinar recording. All right, now let's get into it. I'm very excited to introduce our presenters for today's webinar. Terri L. Wilder is the Manager of Health and Economic Security Policy at SAGE. In this role, she develops and advances SAGE's comprehensive health and economic security policy agenda, with a focus on LGBTQ plus older people and older people living with HIV. Her work centers on federal, state, and local administrative and legislative advocacy goals that are both practical and impactful. And we also have Bridgette Picou, a licensed vocational and certified AIDS care nurse in Palm Springs, California. She works for the Well Project as the stakeholder liaison representing the interests of women living with and affected by HIV in medical research, policy, and advocacy spaces. Bridgette is a director at large for ANAC, the Association of Nurses in AIDS Care, and a sitting member of the board of directors for HIV and Aging Research Project, Palm Springs. Her column in Positively Aware magazine is her unique and feminine take on life while navigating a positive HIV status and frame of mind. Sitting at the intersections of being black, a woman, and living with HIV, her goal is to remind people that there are lives being lived behind a 3 or 4 letter acronym. So excited to have you both with us today, and I'm ready for you to take it away. I think the audience is ready too. Terri, take the mic and on we go.
Thanks, Darren. Appreciate this opportunity on National HIV and Aging Awareness Day. So I'll do a brief description of myself. I am a white woman with long, dark brown hair with bangs. I am wearing purple eyeglasses, and I have on a blue dress with white flowers. And I just need the slides to be brought back up. Great, thank you so much. So today our topic is exploring the impact of aging with HIV, resources, insights, and lifespan considerations. Next slide, please. So our learning objectives today are to identify key demographic trends and epidemiological data related to HIV and aging in the United States. We'll define common health concerns and unique challenges faced by older people living with HIV, and describe available resources, services, and best practices for supporting the health and well-being of people aging with HIV. Next slide, please. So I wanted to take just a minute to share with you about the organization that I work for. So I work for an organization called SAGE. And I think you can go to the next slide. We are the world's largest and oldest organization dedicated to improving the lives of LGBTQ plus elders. That also includes older people living with HIV. We've been around for a very long time. We were founded in 1978, and our headquarters are in New York City. We also have an office in Florida. I work for SAGE from Minnesota. I'm coming to you from today. Like I mentioned, we are an organization that has far reach. We are a national organization that offers supportive services and consumer resources to LGBTQ plus older people and their caregivers. We also advocate for public policy changes that address the needs of LGBTQ plus elders, including people aging with HIV. And I work on the public policy team. You'll also note that at the bottom of the screen is our website, which is www.sageusa, which is SAGEUSA.org. Next slide, please. So I'd like to just start by just talking about the fact that the number of older people with HIV is increasing, not only in the United States, but around the world. And there's a couple of reasons why that's happening. folks who were diagnosed with HIV in the 80s and 90s are now living to their 50s, 60s, 70s, 80s, and even some folks are 90. And that's because of the miracle of science and treatment to help folks stay alive. The other reason why the number of older people with HIV is increasing is because we're seeing folks who are 50 and older acquiring HIV later in life. And that together is why we're seeing the number of older people with HIV increasing. Next slide, please. So I just want to go over a couple of key facts that might be of interest to you and often are pretty surprising to folks. So right now in the United States, approximately 54% of people living with diagnosed HIV in the US are age 50 and older. And about 16% of new HIV diagnoses are among people age 50 and older. But this next fact that I want to share with you is actually something that is very concerning to me and really represents to me a failure in our ability to provide education and HIV prevention services. And it also ties into, I think, something that we're all concerned about, which is the way that ageism impacts people's lives. So among people age 65 years and older, about 34% of new HIV diagnoses in 2023 were classified as stage 3 AIDS at the time of their diagnosis, indicating late stage disease. So what this means is that when a person was diagnosed with HIV, they were concurrently diagnosed with AIDS. And so what that says to me is that we weren't having sexual health conversations with folks. We weren't providing HIV education. We weren't making sure folks had access to HIV testing or having conversations about PrEP, which is either a pill or an injection that folks can get to prevent themselves from getting HIV. And I can't help thinking that this might be the intersection of ageism and how we often think of people who are older as not sexual beings or having a sex negative attitude in general. But one of the things that I think is important to remember is that this doesn't have to happen, that we should be thinking about health education that includes HIV and the work that we do with older people, and that there's opportunities here to make sure that folks get access to the services and get access to the information that they need to make choices about their health. I'll end with the facts by saying that in some parts of the country by 2030, we will see up to 70% of people living with HIV will be age 50 or older. And I can give you one example right now. In the city of San Francisco, folks who are living with HIV, we're already seeing about 70% of folks living with HIV in that city are 50 and older. Next slide, please. So this is a slide from the Centers for Disease Control and Prevention. And this is the stage of disease diagnoses among persons with HIV by selected characteristics for 2023. And so what I wanted to just highlight here, this is just a graph from a larger slide that had lots of other data points. But what I wanted you to look at here is just some of the data about the age of diagnosis, looking mainly at the 45 to 54 age cohort, the 55 to 64 age cohort, and folks who are 65 and older, to give just a snapshot of the percentage of people in those age cohorts that were diagnosed with HIV. Next slide, please. So let's take a deeper dive and look at Minnesota. So as of December 31st, 2023, we had around, let's just kind of move up the number, around 10,000 persons living in Minnesota with HIV. This number includes about 2,807 persons who were first reported with HIV or AIDS elsewhere and then subsequently moved to Minnesota. The number excludes about 1,822 persons who were first reported with HIV or AIDS in Minnesota and then subsequently moved out of the state. So, when folks think about, our state compared to the rest of the country, we definitely do have a good number of people who are living with HIV who still need services and support around the state of Minnesota. And a good percentage of those folks are 50 and older. Next slide, please. And before I go on, I just want to note I'm seeing that somebody in the chat needs some assistance with captioning. So when we look at the state of Minnesota, I thought it would be important to kind of look at the state and how it's kind of divided up. I think most folks think that HIV is something that only happens in a city. But as you can see here on this slide, it shows the number of people living with HIV in the city of Minneapolis, which is about 3,248. The city of St. Paul, 1,137. And then in the suburban areas, 3,694 people. In greater Minnesota, 1,903. So I'm sharing this slide to kind of represent the fact that people living with HIV live in Minnesota across the state. So not, everyone who's living with HIV just lives in the Twin Cities. Next slide, please. So this slide is a chart that shows the persons living with HIV and AIDS in Minnesota by age group. And so this is data from 2023. And so again, you'll notice the last three bars that represent folks 50 to 54 at 1,231, folks 55 to 59 representing 1,364 people. And then the very last bar representing people 60 and older at 2,563. So we definitely have a community of folks who are older and living with HIV. Next slide, please. So I want to talk here about some challenges that are unique to older people with HIV. Several of us over the last couple of years across the country have been holding listening sessions with older people living with HIV. We held 2 listening sessions at previous United States Conference on HIV and AIDS, and then 1 listening session at an event called AIDS Watch, which is when we get together in Washington, D.C., and educate our elected officials. And some of the things that we found out during the listening sessions is that older people with HIV have difficulties in accessing and managing comprehensive and integrated healthcare and social services. We have a number of HIV clinics across the state of Minnesota. But when we think about aging services, and in particular going to a specialist like a gerontologist who is an expert in aging, we know that in the entire country of the United States that we don't have enough gerontologists to meet the need. So it's difficult for folks to access HIV specialists who may not have aging experience, and then it may be hard to access gerontologists who are those experts in aging, and kind of melding the two of those into integrated healthcare. There's definitely a need for mental health programs and substance and alcohol use treatment programs. We certainly know that the COVID pandemic exacerbated mental health and feelings of isolation and loneliness. We've heard from older people with HIV that they, in general, have experienced isolation and loneliness. Many of them lost hundreds of friends at the beginning of the HIV epidemic before we had effective HIV treatment. And as they get older, they're starting to experience more isolation and loneliness and have a great need for opportunities to socialize and engage in activities with others. We also heard that there's a need for housing that's safe and affordable, access to food and nutrition, employment opportunities, and other socioeconomic support services. I think we all know that this year we've all seen our grocery bills go up higher. Rent is certainly going up. And so these are things that are really affecting this particular community. We also heard that folks are having a need for long-term care and community home and community-based services. We know that for older people living with HIV and older LGBTQ plus adults, they're more likely to end up in institutionalized care because they tend to have more experience with not having children or families that are available to provide that type of care. So really thinking about, are we prepared in our nursing homes, assisted living, and our home and community-based services programs? Are we going to be able to meet the needs of this community? I touched on this next bullet point, need for programs that address loneliness and social isolation. But I want to add just a little caveat to this. This might be a good time to think about bringing back buddy programs. In the 1980s and 1990s, a lot of HIV organizations had what was called buddy programs, where a volunteer would be connected with a person living with HIV, and they would provide social support, in the form of phone calls or going to see a movie together or taking a walk in a park to help address loneliness and social isolation. And it may be time to think about bringing those types of programs back. And finally, another challenge that was shared with us is the need to dismantle stigma and discrimination. HIV stigma and discrimination is not something from the past. It's something that happens every day. Stigma can come in the form of like really overt stigma, like using, behavior that is not nice to people simply because they're living with HIV. It comes in the form of the language that we use that can be incredibly stigmatizing. It can be discrimination we see in folks not being accepted into nursing homes because they're living with HIV. So this isn't something from the past. It's something that we still see even today. Next slide, please. So I want to talk a little bit about the intersection of aging with HIV and kind of how having HIV can often accelerate the aging process. We know HIV, the human immunodeficiency virus, affects chronic inflammation in the body. And so simply by having HIV, it may increase the onset of age-related health conditions and risk for other chronic health conditions. So we often hear folks who are older with HIV talk about that they're dealing with multiple comorbidities and polypharmacy issues at an earlier age compared with people without HIV. So it's really something to kind of think about in terms of early screening, making sure that folks are getting to their medical providers, to make sure that we're tracking these kind of things so that treatment and care and prevention can be provided for comorbidities that have the ability to be prevented. Next slide, please. So just to kind of unpack this a little bit more, what we know is that more than 80% of people living with HIV will have at least one age-related medical condition, such as cancer or heart disease. Next slide, please. And that many of the health issues now faced by people with HIV actually have more to do with aging than with HIV-related illness. So, for example, in the early years of the HIV epidemic, we found that people were dying of AIDS-related complications. But when folks are on effective treatment, what we find is that they're not dying or dealing with AIDS-related complications, but they're dealing with things related to aging that folks without HIV might be dealing with. So one of the things that constantly came up is that thinking about quality of life is really very important and should be a priority as we're thinking about working with people aging with HIV. That just simply thinking about the medicalization of the navigation of the medical system isn't just the most important thing to a person's life. It's important to have medical care, but it's even more important to a lot of the folks that we spoke of to have a quality of life. Next slide, please. So some best practices to think about as we close out here is really coming up with ways to integrate HIV care with existing aging and disability services. We're finally starting to hold hands between the HIV community and the aging community and the disability community. For a very, very long time, we've kind of been isolated with HIV over here, aging over there, and that we're really starting to realize that we can really learn from each other and our respective expertise, and that we could really collaborate with each other in making sure that we're providing the best care and support to the community. Another best practice is to really find ways to support folks' medication adherence and regular health monitoring, considering the comorbidities and the polypharmacy that folks might be dealing with. Thinking about screening for comorbidities common in older people earlier than one might think, for things like heart disease, diabetes, bone loss, and mental health. Promote social connections to reduce isolation. I remember when I lived in Atlanta in the early 90s, we'd have what's called Pwarties, which is PWARTY, so people with AIDS party. And it was just a time to get together on Friday evenings and socialized and have food and beverages together. So thinking about ways to bring some of those kind of activities back. And also another best practice is to strive and challenge all of ourselves to provide stigma-free, culturally sensitive care. And ways to do that can be things like learning about the NIAID HIV language guide and reading it to make sure that when you're writing or that you're speaking, that you're using language that's not stigmatizing about the community. And finally, another best practice is to have peer services, hire older people living with HIV to provide services to the community. Who knows better what it's like to live with HIV than a person with HIV? It helps people connect with each other. It's a trusted person in the community. They actually can relate to what the person's going through. So finding ways to hire and include peers in the work that you do is always a best practice, and there's great models across the country for that. Next slide, please. So I'll just say a word about the importance of MIPA, which MIPA is an acronym. It's MIPA, that stands for the meaningful involvement of people with HIV and AIDS. And one of the things that I can say is that from the very, very beginning of the HIV epidemic, people living with HIV were involved in how care was delivered. They often created their own programs for the community. And we can look back to even 1983 with the development of the Denver Principles, which is a document that you can find online to read about these principles. And these principles really set the standard for how people living with HIV want to be treated, how they want to be referred to, that it's imperative that they have a seat at the table to make decisions about their lives, that they are a partner with their healthcare provider. And so very early on, MIPA was important to this community and making sure that their voice was heard and included in any conversations. I've already mentioned the NIAID HIV language guide, which is a great document to read about how to write about HIV, how to talk about HIV. And then I also want to highlight the United States People Living with HIV Caucus, which is a group of folks living with HIV who work together on policy and education and really embraces the spirit of MIPA. Next slide, please. So I'll end here by saying thanks so much again for inviting me to be a part of this important conversation on this Awareness Day. I encourage you to stay in touch with me. My title has changed since I put these slides together. And I am very passionate about this work. I'm a social worker by training, and I've worked in HIV since 1989. And I feel honored to get to basically fight for my friends every day, who are people who are 50 and older living with HIV. So this is personal to me, and appreciate the opportunity and look forward to hearing from my friend Bridgette Picou next. Thank you.
Terri, thank you so much. Virtual round of applause for that fantastic presentation. And I want to take a moment and thank the organizers for having both Terri and I, having me in particular. I always appreciate the opportunity to share my lived experience. So I'm going to talk about exploring the impact of aging with HIV a little bit, from a lived experience perspective. So for those who are listening, I am a 52-year-old Black woman. I have curly red hair that comes from a bottle and will continue to come from a bottle forever and ever. Amen. And I also have dimples. I'm wearing gray-rimmed glasses. A little bit about me is that I am a nurse by trade. I have been living with HIV coming into my 14th year. So not as long as some folks that I know and some people that I've taken care of, but it can start to feel like a lifetime for a person when you're living with HIV. So the first thing that I want to talk about, and one of the main things that I hope you all take away from this, is that people living with HIV and aging with HIV specifically need to feel supported. We need to feel like we are being ushered into age by not surrendering more of our power. When you are living with HIV, there are so many ways in which you give up little of your power through battling against stigma, fighting against the fear that people have when it comes to HIV and AIDS, the ignorance of people just not knowing what HIV is or isn't. And so that sense of personal dignity is really, really important. And the community in which we surround ourselves and the folks who are there to support us are critically important. I cannot say enough about how much community matters when it comes to living with HIV. And community is not just the people around us. Our community is also made up of the folks who take care of us and who provide services for us. So I want to kind of level set a little bit about aging, right? Aging is the set of biological, physical, mental changes, general changes in lifestyle that happen as we grow older, as our cells grow older, as our bodies grow older. In general, folks start to consider people aging, in quotations, at about 50. For most services, such as Social Security, for example, aging and older adults or elderly adults is considered 65. Specifically, the benchmark for people living with HIV is 50. And that is because mostly related to the fact that we have immune dysfunction, or our immune function starts to decline because of the chronic inflammatory nature of HIV. I have been aging with HIV since 40. So Terri talks a little bit about how folks were being diagnosed with HIV later in life. At 40, that was not what I anticipated having happen to me, right? 40 is supposed to be the age where you are coming into your own, right? You start to not care about things that you used to care about. It's an age of freedom. It's an age where women hit their sexual stride. All of these things were doors that I expected to open up at 40, and instead I ended up with an HIV diagnosis. So navigating that has been a little bit of a challenge. So not only am I navigating hitting 40, headed towards older age, now firmly in menopause and living with all of the changes that menopause brings, but also HIV. So it's critical that we consider the whole person when we talk about aging and the whole person's experience when we talk with HIV. The other thing that Terri touched on that I want to dive a little bit deeper into is stigma. Unless you have experienced HIV stigma, it's really hard to understand the depth to which it can really impact a person's life and themselves. It is a very real and very layered concern. Stigma includes external stigma, internal stigma. There is enacted stigma, what happens to us specifically, and then there is perceived stigma, which is the idea of what might happen to us, right? How people might treat us walking into certain situations. HIV stigma intersects heavily with all of the other isms: ableism, racism, all of those things, right? Added to that, there's also the layer of heteronormativity, cisnormativity, because HIV doesn't have a face anymore, right? Not that there's not one particular cookie cutter type who acquires HIV. I certainly never would have been what people considered as vulnerable to HIV. And yet here I am. And so all of these things intersect, and I explain it this way. Sometimes living with HIV is like a pancake thin layer across your life. And then there are other times life with HIV is as thick as a mattress, right? And it depends on where you are in the ebb and flow of your HIV journey, of your journey taking medication. And stigma is fluid, I guess is the best way to put it. There is a relative relationship between stigma and HIV. It's impacted by the systems of support that you may have or may not have. And it also is, again, like I said before, directly related to the amount of support and community that you have surrounding you. And so as folks who are looking after people with HIV, it's important to keep that in mind. HIV stigma can be correlated with depression, with anxiety. It definitely has an overlap with loneliness and isolation, which we know is a concern for older people. And so it's even more important that we do our best to make sure that people living with HIV and aging with HIV are not dealing with that particular form of isolation. We have our families oftentimes that take care of us. I don't know about in other communities, but a lot in Black communities, intergenerational caregiving is a thing. And so there are multi-generations living in one household, which provide kind of a built-in support system. If you are a person who is part of the LGBTQ plus community, maybe you have chosen family because you don't have a relationship with your birth family because of what they consider to be lifestyle, right? That's a form of stigma, the rejection, all of those things. And so it's really important that as folks age with HIV and age with their chosen family, that we're keeping an eye on the fact that sometimes chosen family is aging at the same time as the person who may be living with HIV. And so those systems of support that they have to be bolstered up. We have to branch out into who's checking on them. Like Terri was talking about the buddy system, which I think is an absolutely amazing program. As a nurse and a person who has taken care of people living with HIV, I know how important it is to check up on someone or to have someone check up on you and to make sure that you have all of the things that you need, right? That your rent is being paid, that you have the food resources that you need in order to be able to take care of yourself. And so being sure that we are supporting, again, the whole person. Stigma, the last thing I'll say on stigma is that stigma can decrease engagement in care and engagement with healthcare systems. And so as people working in the healthcare system, it's important that we're checking in on folks living with HIV. There is a movement in language to differentiate away from calling people in medical spaces patients. I have a love affair with the word patient because I think there's a very special relationship between patients and nurses. And as a nurse, I feel a way about my patients. And so that's why I use that word. If clients is the word that you prefer to use or that the people that you're engaging with prefer to use, then by all means, use that word. But whether you call them clients or patients, it's critical that you're checking in and making sure that we are okay. There's some common concerns. Terri talked a little bit about some of them. There's going to be a little bit of overlap. But aside from the co-occurring conditions that people may experience, also known as comorbidities, like your heart disease, kidney disease, and polypharmacy. Polypharmacy is often talked about because of the concern of interactions with HIV medications or interactions with the multiple medications that people may be taking for their co-occurring conditions. Unless we're asking questions, we don't know. And oftentimes people don't know what questions to ask unless they're familiar with it. And so even if you're not a nurse, even if you're not a clinician, as a social worker, as a peer navigator, as a peer support person, you should also be asking us, and by us, I mean people living with HIV, about our medications so that it's often front of mind and so that we can remember to address issues that we may have taking our medication or even with accessing our medication. Cognitive health. And this is something that I've been thinking a lot about because, as I said in the beginning, I'm in menopause and the brain fog is a lot. But when we talk about cognitive health, often people go right to memory, but it's more than that. It is our ability to think, it's our ability to reason, it's our ability to continue to learn things. And so cognitive health should be addressed regularly by everyone that we come into contact with as we start to hit that 65-year-old benchmark. There are other things that HIV impacts. So aside from dementia, aside from Alzheimer's, aside from what is considered quote unquote normal cognitive decline, HIV-associated neurocognitive disorder, which is also known as HAND, is an issue. It's not as much of a concern now as it was back in the beginning of the AIDS epidemic because medications have improved so much, but it does happen. And so that's an additional layer of concern that people need to have, and it's something folks need to look out for and be reminded of so that when you start to see cognitive issues or what you may think are cognitive concerns in a person living with HIV, it needs to be examined by a specialist so that we can actually figure out what the issue is. We talk about blood pressure, high blood pressure being a silent killer. I'm here to tell you that isolation is the other silent killer, particularly with HIV, because of all of the layers of stigma, because of the fact that depression is layered on top of that. Anxiety is layered on top of that. Each thing with when it comes to HIV is connected to the other and adds a layer either on top of or beneath whatever the concern is. So isolation is absolutely a silent killer because people often sit in silence and they don't talk about the fact that they're feeling lonely or they're feeling isolated or, they're scared of what's going to happen if they tell someone their status. They're scared of being rejected if they tell someone their status. And so we have to make sure that we are aware of, and again, I can't stress it enough, checking in on people. Mental health is a critical concern because we know how backwards and broken the mental health system is. People living with HIV face greater numbers of mental health issues, specifically depression, because there's an element of depression in just the virus itself, living with HIV itself, the inflammatory process of HIV itself. And then the last thing I'll kind of say on this is we have to ensure that people have access to age appropriate or condition appropriate care. And so what I mean by that is condition appropriate care is obviously seeing an infectious disease specialist who knows about HIV. We are losing a lot of our clinicians, either due to age, retirement. The specialty is not one that is attracting a lot of new talent, so to speak. And so our pool of providers is shrinking. From a personal perspective, I have had 8 HIV clinicians in my 13 years of living with HIV. That is crazy, right? It's way too many clinicians for me to have had. It is a blessing that I am a nurse and I'm able to navigate the healthcare system. But every time I talk about that, it makes me think about the people who don't have the access to navigate the system in the ways that I do. And so it reinforces what I'm saying about making sure that we are checking in on folks and that we know what's happening with them. The other concern, Terri kind of mentioned it, is geriatric care. There are not enough geriatric care providers, let alone those who understand HIV. And so when we start to get into that realm, we're talking about fragmented care. Many of us, myself included, use our infectious disease specialist, our HIV doctor, as our primary care doctor. I have been finding out as I'm aging, right? I have a knee concern, so I have to see a specialist for that. Fortunately, I don't have a heart condition or those concerns, but I know folks who do. So that's another specialist that they have to see. If someone has diabetes, that's potentially another specialist that they have to see. And all of this is happening in different places, right? They're often not in the same building. And so what are we doing about bolstering systems of transportation to make sure that people are getting to these appointments? Health literacy becomes a concern. How are we ensuring that folks understand how to navigate the system and also how to navigate what disease process they may be dealing with? So looking at the whole person for an older adult is a multi-layered, multi-faceted concern that requires multidisciplinary intervention. And that is where our social workers come in. That's where our peer navigators come in. And that is why it's so important that you have at least a working knowledge of HIV and what it is, and all of the things that I've talked about and all of the things that Terri has talked about that address the whole person so that we're taking care of the whole person. And I keep saying whole person because I want it to stick in your head. And I want people to understand that HIV is absolutely 100% not just a viral process. It is so much more because it impacts every single aspect of the life of a person who is living with HIV. At 53, I still consider myself to be vibrant. I still consider myself to be a person who wants to date. I'm single. I'm looking for love. Hopefully at some point between now and then, I have some really great sex. Older adults are still having sex. So looking at us through the lens of being complete and whole people and not just the virus makes all of the difference in not only the care that we receive, but also in how we feel about ourselves. Feel about ourselves impacts how we feel how we feel about stigma impacts how we engage in day-to-day life. It impacts how we engage in care. It impacts whether or not I'm going to be compliant or dedicated is the word that I prefer to my medication. My medication every day makes all of the difference for how I feel overall in my health. You see where I'm going with this? Everything touches everything else, and everything is layered upon each other. And so that's why it's so critically important that we have conversations like this, and that each one who is in this space intentionally takes what they've learned and brings it to someone else so that we can increase the knowledge and decrease the fear and decrease the ignorance that is all of the things surrounding HIV. Round things off, talking about some best care practices for what I think are important considerations for people living with HIV and how our healthcare community can help us and how our healthcare community can engage with us. Number one is encouraging shared decision-making. Shared decision-making should not just be between the patient and their clinician. This should include their nurses, their social workers, their pharmacists. The entire care team should be engaged in shared decision-making, and the entire care team should know what is going on with the other cogs in the wheel. It's very easily to specialize things and send folks off to have someone else deal with what is happening if it's not your specialty. But I feel like everyone should know a little bit about everything so that we can offer support in the ways that a person may need to feel supported. Again, I'm going to stress, best care practice is community, 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 community. Community is built of the people that we live with and that are in our neighborhood, the people that we commune with most often. Community is our healthcare providers. So community is critical to us, again, feeling empowered and like we're not feeling empowered some of that power that we need in order to navigate life with HIV. Advocacy is important. Self-advocacy is critical. I am my own best advocate. However, I need people to advocate for me. There are some people who are not comfortable speaking up about what their HIV status is. There are some people who are not comfortable speaking up about what life is really like with HIV, and that is where advocacy comes into play. We have to bolster the systems of both advocacy and healthcare so that folks are able to go into a space and advocate for themselves. In some cases, we need to create new systems to help support people. Again, I'll go back to health literacy. Health literacy is critically important in making sure that people understand what is going on with them and what their healthcare process is. We need to remind people that they have to have a backup plan for the backup plan. Oftentimes, we don't have a plan for how we are going to age. Things are very uncertain right now, and things are changing a lot right now. So it's really, really important that we help patients visit what their plan is and how they're going to move forward. And then also, policy impacts are really important. We talk about social determinants of health all of the time in healthcare, but it's also important to remember that the political determinants of health drive the social determinants of health. And so we should have an understanding and be able to explain to folks living with HIV, particularly older folks living with HIV, as they navigate Social Security assistance, Medicare assistance, the changes in Medicare, the changes in how their drug coverage works. All of those things are driven by policy. And so we have to keep policy impacts in mind as we consider what is coming down the pipe for healthcare as we are taking care of older or aging adults with HIV. And lastly, let me say this. In my time living with HIV, I've been through a lot. Navigating HIV and learning how to advocate for myself was the most important thing that I could have done. But I remember very early on in the beginning of my diagnosis, I didn't know any of this, and I didn't know how to do any of this, and I was extremely lost. I became a nurse after my diagnosis, not because of it, but because I needed something to do with the rest of my life. But it ends up being in the funny way that the world has a way of working that I did become a nurse because of my diagnosis. I feel like I'm planted right now in work that I'm supposed to be doing. I feel like this is part of my purpose. And while I would 100% give my diagnosis back if I could, because I am ostensibly with it for the rest of my life until there's a cure, we are learning how to live together, and we are learning how to navigate life together. And I could not have done that without community. Terri is a big part of my community. I love her to death. I've learned so much from her. And it's important that all of us have someone in our corner just like that. And so each of you who is on this call has an opportunity to be that person and to be the person that can help someone navigate life with HIV. And so I would encourage you to use the information that you have, the tools that you have, things that you've learned on this webinar, things that you may learn in the future. I encourage you to take those with intentionality to improve and support the life of someone living with HIV. I can tell you that we'll appreciate it. I know that. And hopefully you gain something along the way as well. Thank you for listening. I think we're going to go into a Q&A session right now. Oh, and also I will put my email address in the chat. I work for an organization called the Well Project. We focus on women and girls living with and or with reasons for prevention of HIV. However, that does not mean that I cannot help anyone and everyone. So please contact me if there's anything that I can do for you.
So, Bridgette, we are
Yes.
going to go over. I think I'm echoing just a second if you want to mute quickly. So Bridgette, you and I are supposed to go over this HIV and aging resources document. So I'll just share with the audience that Bridgette and I put this document together so that you have very specific HIV and sometimes HIV and aging resources literally at your fingertips. And it's just a nice kind of directory. And so at the top, you'll see that we have it listed as national advocacy and community organizations. And Bridgette, if you don't mind, I'll do the first section if you want to do the second section, unless you have a preference. So the Well Project, which is where Bridgette works. And then the second resource you'll see is SAGE, where I work. The third resource is the Reunion Project, which is also a national organization that does a lot of programs, webinars. Sometimes they even come in person to do workshops. I know in the past several years, they've done some really incredible educational forums for people living with HIV around working and how to find jobs and keep employment as you age. Ribbon is another national organization that does a lot of great work around HIV and aging. Let's Kick Ass, which is kind of a funny name, but ass is not what you think it stands for. It's not your bottom. It stands for AIDS Survivor Syndrome. And this is kind of where a lot of information came around as folks living with HIV lived longer and longer. There were some signs of post-traumatic stress disorder that were very unique to living with HIV, because of losing hundreds of your friends, seeing how society had treated people in a very awful way. So really thinking about, how is living with HIV and kind of living through this trauma of kind of things that had happened in the past, and how can folks come together and support each other. So I'd encourage you to go to that website. The Dandelions movement is an important part of this conversation around aging with HIV. We tend to think of people older aging as 50 and older, as both Bridgette and I referred to. But there are people who were born with HIV that are 20, 30 years old. Some people are approaching 40 years old, and their bodies are aging with HIV, and they're seeing some of these co-occurring diseases and comorbidities happening. They have, lived their lives and had some challenges around being a young person who's growing into an adult or an older person with HIV. So I'd encourage you to go and check out the Dandelion Movement website. NMAC, which is the National Minority AIDS Council, actually has a 50+ strong and healthy program. And they have meetings together virtually. They often join together at the United States Conference on HIV and AIDS. So if you have clients who are living with HIV who are 50 and older, if you are a person living with HIV that's 50 and older, I encourage you to check out the 50+ strong and healthy program. The Federal AIDS Policy Partnership, which we lovingly refer to as FAP, is a group of folks who are kind of policy nerds. I include myself as one of those. And we work on policy. Within FAP, there is an aging working group. GMHC, which historically refers to as the Gay Men's Health Crisis, and ACREA has a National Resource Center on HIV and Aging that you can go to. And then there's a National Resource Center on LGBTQ plus aging, which SAGE runs, that has HIV and aging materials on it. So we thought that might be a helpful kind of starter list of some community national organizations. And now I'll turn it over to Bridgette to talk about these clinical provider focused ones.
Excellent. Thanks, Terri. I'm sorry for that part. So just to add, on the Well Project's website, we have partnerships with over 50 organizations. So if you go to the Well Project's website and click on our partners, there are additional resources available there that may help with you finding anything that a person aging with HIV might need. So for our clinical focused resources, we have listed here the AIDS Education Training Centers, AETC. AETC is amazing for the information that they have available on all things related to HIV, including research, clinical items. It's a great resource. The Association of Nurses in AIDS Care, shout out to ANAC, which is what it's lovingly known as. I'm on the board of directors of ANAC. ANAC was started early on in the HIV/AIDS crisis as a resource and education space for nurses who were taking care of people living with HIV, who at that time were dying with AIDS. And so the organization has grown tremendously. They offer resources, training, education for nurses, but it is not just a nursing organization. I want to stress that. We welcome any allied healthcare provider or person doing the work in HIV. The Academy of HIV Medicine, also known as AAHIVN, does training for clinicians. Association of Social Workers in HIV and AIDS Care. PASWA is the acronym for that. Great organization. I'm sure some of you on this call are familiar with them. Encourage definitely joining and gaining some more education and training around HIV. The HIV Medicine Association, also known as HIV-MA, is a national HIV and aging initiative. Again, they focus a lot on training for clinicians and providers. And then lastly, we have, I can't see it so tiny, the Minnesota Northeast Geriatrics Workforce Enhancement Program HIV and Aging Toolkit. Great resource. All of these are resources that I encourage you to at least click on and see what they have and how it may benefit you. Again, that's that intentional part of taking what you're learning today. And then specific to Minnesota services and supports. Terri, you want to talk a little bit about this one?
Yeah, sure. So we put a little group of Minnesota services together. So the Minnesota Aging Pathways, which is formerly the Senior Link Age Line, the AIDS Line, which is kind of run out of the Aliveness Project, has information and referrals for specific HIV services. And then the Minnesota Department of Human Services has information about the Minnesota Ryan White program, eligibility, and information to apply for these services. I do want to go back up to the social work group and just say that for the Professional Association of Social Workers in HIV and AIDS, which Darren is heavily involved in, they actually have a certificate program in HIV and aging. So I encourage you to go to that website to learn more about that certificate program. There's several modules that folks can take to get certified in HIV and aging. Sorry, I jumped around, but if we want to scroll on down, I can finish this out. Oh, wow, we've really put a lot together here. Guidelines and research. The New York State Department of Health has some HIV and aging guidelines that I think are excellent. They're for clinicians, but I think anyone can read them and get a lot out of them. Health HIV, State of Aging with HIV. They have an annual report that they do on HIV and aging. So they now have their 4th report out that I encourage you to check out. The National Institutes of Health has an HIV and aging webpage that has some great information. In terms of policy and legal resources, we're really lucky in the last year. The Center for HIV Law and Policy just released an Aging and HIV Legal Primer, which is excellent. Kay Greenberg, who's the lawyer there, was the lead author on that. The Georgetown O'Neill Institute, literally around the same time last year, released their report on HIV and aging systems integration, which I should say was informed and created with people living with HIV. And then SAGE, where I work, we are currently in Minnesota working to pass an LGBTQ plus and HIV long-term care Bill of Rights with a number of coalition partners. And here's a toolkit if folks are interested in learning more about that. They can read that information in the toolkit, or you can reach out to me if you're interested in joining our monthly coalition meetings. And then finally, just some media and information hubs. The Body website and the Body Pro website both have HIV and aging sections. HIV.gov's website has aging with HIV information. AIDS Map, which is another website, has HIV and aging information. And then finally, HIV.gov has information on the reason why we're here today, which is the National HIV and Aging Awareness Day, which is always September 18th. So I think that rounds out our resource page document that we put together, and I know that that will be sent out to you. And I think we were going to go to one of our poll questions just to see if folks were listening.
So the question is, in the United States, what percentage of people are living with HIV aged 50 and older? Take a swing at it. And don't worry if you get it wrong, because we're going to tell you what the right answer is, which technically means there's no wrong answer. How about that? You can see the number climbing of people who are responding. So thank you for participating. Many of you are responding in the chat too, which is awesome. I think we have these on a timer, and it should be coming up. And someone in the chat is asking, yeah, in the US. And I think our answer is coming up.
So Bridgette, I think we have to tell them the answer. I don't think folks can see it. Do you want to give them the magic number? Or I can share. The answer is 54%. So the percentage of folks living with HIV in the United States over 50 is 54%. So we have about 1.2 in the United
Sorry, I couldn't unmute. I was trying, it wouldn't unmute.
So we have 1.2 million. Oh, Bridgette, I'm echoing. So we have about 1.2 million people living in with HIV in the United States, and 54% of those folks are 50 and older. So that's our answer. And so now I think we're going to question and answer.
Hello. For some reason, my video has me incognito. We'll try to fix that. I do not know why it is doing this. Let me make a quick. Here we go. Ah, yes, here we are. I apologize for that. We have some questions. I will start, and this will be to both Terri and Bridgette. Both of you can take a shot at this one. Take a chance at this one. The first question is, if someone here wanted to make their organization more welcoming and accessible to older people with HIV, what's one concrete step they could take right away?
You want to go first?
Bridgette, I think you should take this one first.
Okay. I can tell you right now, there's a weird kind of thing when it comes to living with HIV. First of all, oftentimes people do not want their status known because of stigma. And so making sure that when folks come in for services, that your front desk is cognizant and aware that not everyone shares their status openly is important. So your receptionist shouldn't be saying you're here for your HIV appointment, things like that. Secondly, language is critically important. So how you talk to and about people living with HIV, paramount. Put the person before the viral process. And then thirdly, just being educated again on what HIV and what it is not. A lot of times people think they know what HIV is, but they are going on what their cousins, sisters, brother told them, right? Instead of looking at new resources, new guidelines, updates, things like that. And so those would be the top three things that I can think of. Maintaining dignity while they are living with HIV is very, very important.
I mean, adding to that, I would say if your organization ever does surveys to get input from the clients that come about what services they need, you know, I would try to include some reference or question about, you know, would people be interested in HIV education or HIV testing at a health fair, to try to kind of get a sense of folks want that kind of service. Or maybe it could be folded into, you know, would you be interested in sexual health presentations or sexual health fairs? And then that way you could include HIV information and services that way. You know, I think another way to just make sure that, you know, folks feel welcomed is, you know, publicly partnering with an HIV organization. I can tell you for today, for National HIV and Aging Awareness Day, we had 3 different organizations reach out to SAGE and say, can we do a collaboration to push out information on social media? So, anything that you can do to show the community, because you have older people living with HIV in your community across the state of Minnesota. It'll be important to, speak about HIV to the press. Use some of the information that Bridgette and I shared today as your speaking points. If you have a newsletter with your organization, write an article about HIV and aging, or hire a person living with HIV to write that article. Because all of these things sends messages that we care about HIV, we care about people living with HIV. It's welcome here. You're welcomed here. We're thinking about you, and it kind of sends nonverbal messages when you have an article, or you do a social media collab, or you have a health fair that has HIV testing. So all of these things people pick up, because they're perceiving you as caring about this issue.
Well, thank you. I apologize, I forgot to introduce myself. My name is Todd Stump. I'm a white male with gray hair that's spiked, blue eyes, wearing a red long sleeve shirt. I will jump to a quick comment here made by Zainab, saying that they were expecting the number to have been higher, considering education given to people younger than 50. And there was also an individual who mentioned, or someone, Hank Jensen, mentioned that MATEC has an event titled Addressing Social Isolation in People Aging in HIV on Wednesday, October 1, from noon to 1 Central Standard Time. Both of these were mentioned in the chat if you missed them. I will throw one more question out there based on the time frame. How do you see the needs of older adults living with HIV evolving over the next 10 years? And what should providers start preparing for now?
I'm really struggling with my mute button right now. That's a really great question. And one of the things that providers can do right now is start to talk to their patients who are younger than 50 about what's coming. Part of the frustration in the community when it comes to HIV and aging is that people are all of a sudden acting like this is a surprise and like it hasn't been coming for a number of years. There absolutely was a time when people did not expect to live more than a few years with HIV, but we have had really good medications for a long time, and people have been aging that entire time. And so it's important that we start having more of these conversations earlier with people that are impacted by HIV. And also education of the younger generation of clinicians is important. I think that reaching out and starting to really have conversations with people while they are in school about HIV and about what HIV care looks like or may look like in the future is really important. We need clinicians who are willing to take care of us. We need clinicians who are also starting to become more versed in the needs of geriatric patients. HIV is very much a specialty, which very much frustrates me. 40 plus years into this epidemic, it should be discussed more openly in more spaces that provide medical care in general, and not just limited to being a specialty. And so the more that we can encourage people to get educated, to get into this field, to learn what, even if they don't want to be an HIV care provider, understanding the basics of medications, the basics of testing, the basic needs of people living with HIV is going to be critically important over the next 5 to 10 years, especially with the way that our systems of health are changing right now. I'm just going to say it that way. It becomes that much more important that we light a fire and keep the fire going. so that we don't lose more than what we've gained. And I hope that makes sense. We've made so much progress over the last 40 years. It would be a real shame to start losing that. And so it's important that we keep the fire lit and keep things moving forward, so that we have that momentum, and so that we don't go back to what it once was and what we once knew.
Yeah, I would echo what Bridgette is saying and just add that, as we think about the future, really thinking about healthcare and social services, really making sure that we're collaborating with each other, that HIV organizations know who the area office on aging is, has a relationship with the folks who are in the state office on aging, making sure that as we're thinking about the Minnesota State Plan on Aging, that there are concrete goals and objectives to make sure we're including, serving older people with HIV, and just making sure that we are really trying to figure out ways that we can partner together. I mean, I can't say strongly enough that we really need to think about bringing back and preparing now for the buddy program. I was a buddy in the late 80s and early 90s. I was actually a buddy captain, and just really found how it really improved people's mental health and really helped reduce isolation and loneliness, knowing that somebody was there to call or go grab a piece of pizza with them. Thinking about practical support teams. I mean, I've not met a person in my life who wants to live their remaining years in a nursing home. So how can we help older people with HIV age in their homes? And so practical support teams was also something that was part of a HIV organization I was part of, where a volunteer of team of 6 or 7 people would come in to help with things like clean the apartment or do the laundry or make sure the dishes were done, so that they could live their life as best they could in the home where they felt more comfortable. So really thinking about these types of collaborative models and working with each other in the aging sector and in the HIV sector to make sure that we're meeting the needs as people age with HIV. And I'm excited that my friends get to live these long, beautiful lives. But I also know that because of living with HIV, there's going to be some particular challenges that happen physically earlier in their lives, that they're going to definitely need some support from the aging sector that kind of is the expert in aging. And, we have things to learn from each other. The HIV community has things to learn from the aging community, and the aging community has things to learn from the HIV community. And it's never too late to start. And I appreciate all of you who came today, because you started today learning about the community and how we can all work together.
I think just to add to that real quickly as well, Terri, is as you talk about the buddy system for individuals, I think organizations can think about buddy systems, right, or partnerships, including, if you are a social worker, make sure you're spending some time in public health where they do testing, right? So you can have a pulse on what's happening and what may be coming. And public health departments making specific inroads and taking opportunities to get involved with aging organizations, so that there really is a cross collaborative kind of effort, as opposed to keeping things in silos, and keeping things separate. And like I was talking about before, sending someone to see a specialist. Those partnerships are really, really important, and are going to become more and more critical as services are rolled back and funding is cut so that each one can support and bolster the other.
Well, thank you so much. That was absolutely fantastic. Before signing off, there are a few reminders. We will be sending out a post-event survey and certificates of attendance within the week to people who have participated in this webinar. Please email any remaining questions to dhs.odyssey@state.mn.us and stay tuned for our future 2025 Odyssey webinar series events on the Odyssey Conference website. I would like for all of us to extend a huge heartfelt thank you to both Terri and Bridgette. It has been extremely valuable to hear and learn from you. Thank you both so much. And to the audience, thank you for joining us today, and we hope to see you at our next webinar. Until next time.